Good day, professors, consultants, other senior colleagues and colleagues. I'm Dr. Olagunju Ganiat from Ahmadu Bello University Teaching Hospital Zaria. Today, I'll be taking us through the physiology of pregnancy and its anesthetic implications using the following outline. We'll go through a brief introduction and see the changes that occur in various systems and their anesthetic implications. We'll look at the implications of these physiological changes in the setting of cardiac arrest in a pregnant woman during cardiopulmonary resuscitation. We'll briefly look at high-risk pregnancy and conclude. Pregnancy occurs following successful implantation of a fertilized egg by a sperm cell. Series of physiological and anatomical adaptations occur in pregnancy to meet the needs of the mother and her growing fetus. These changes are largely due to estrogen and progesterone, and these adaptations have many implications for the anesthetist caring for pregnant subjects. Looking at the cardiovascular system, the blood volume increases progressively from 6 to 8 weeks, peaks at about 32 to 34 weeks, with little change thereafter. And in the healthy pregnant woman, this change in blood volume does not lead to circulatory overload. Plasma volume increases by 40 to 50%, while red cell mass increases to a lesser extent, 20 to 30%. This results in hemodilution and a decrease in hemoglobin concentration. Thus, pregnant women should receive iron and folate supplementation in pregnancy. The importance of the increase in blood volume is to facilitate maternal and fetal exchange of respiratory gases, nutrients, and metabolites, and to also reduce the impact of maternal blood loss at delivery via autotransfusion of blood from the contracting uterus into the maternal circulation. To the left is a graph depicting these changes. Cardiac output is increased by 30 to 40% in the first trimester as compared to the non-pregnant states. This is due to a major increase in stroke volume and a lesser increase in heart rate. The stroke volume rises by 35%, while the heart rate increases by 15%. We know that cardiac output is stroke volume multiplied by heart rate. So cardiac output will increase. The systemic vascular resistance, on the other hand, falls steadily due to development of a low resistance vascular bed in the placenta and the vasodilatory effects of progesterone, estrogens, and prostacyclin. The decrease in systemic vascular resistance contributes towards the hyperdynamic circulation seen in pregnancy. During labor, there is further increase in cardiac output, which can be blunted with the institution of labor analgesia. It is said that during labor, cardiac output increases by 50% of pre-delivery values, and immediately after delivery, it can rise as high as 80%. Following delivery, autotransfusion compensates for the blood losses and increase in cardiac output by 50% of pre-delivery values. At this point, stroke volume increases while the heart rate falls. The left ventricular work of the heart is increased by 40%. So in parturients with a pre-existing cardiac disease, this is a high-risk period as the increase in the left ventricular work can lead to myocardial ischemia or heart failure. The blood pressure falls during normal pregnancy. systolic blood pressure falls by about 8% by mid-gestation and returns to normal by term. The diastolic blood pressure falls to a larger extent by as much as 25% by mid-gestation. This also returns to normal by time. Vascular tone is more dependent upon sympathetic control than in the non-pregnant state, so that hypotension develops more readily and more markedly following sympathetic blockade upon institution of a centrineural anesthesia. There is also a reduction in afterload and an increase in preload. Together with the increase in blood volume, this can give rise to functional murmurs. Aortocaval compression is compression of the inferior vena cava and aorta by the gravid uterus. It occurs during pregnancy, reducing cardiac output. The severity of this effect is dependent upon patient's positioning, the gestational age, systemic blood pressure, and presence of sympathetic block. The inferior vena cava compression develops from 18 weeks gestation, the effect becoming maximal at 36 to 38 weeks. This diagram depicts cross-section of a pregnant woman lying supine on the left, and the diagram on the right depicts the same woman lying with a left lateral tilt. Thus, a wedge has been placed. Now, looking at the major blood vessels, the inferior vena cava depicted in blue and the aorta are both compressed when the woman lies supine. The inferior vena cava is a low resistance vessel, so the compression is more than as obvious in the aorta. And this leads to pooling of blood. There is an obstruction to venous return, and then subsequently reduced cardiac output, such that when the heart pumps the reduced cardiac output, the supply by the aorta from the distal to the region of compression is also reduced, and this can impair supply to the fetus. Then the diagram on the right, there is a wedge which displaces the uterus such that the extent of compression is minimal. It also occurs on the right, in the left lateral tilt, but to a lesser extent as compared to when the woman lies supine. Supine hypotension syndrome ensues following lying in the supine position beyond 20 weeks gestation. And up to 8% of pregnant women experience supine hypotension syndrome, which is characterized by a large drop in blood pressure, causing systemic signs of shock and syncope. Arterial hypotension can be observed in the lower extremities and in the uterine circulation. This can lead to fetal asphyxia and bradycardia. Looking at the cardiac size, position, and the ECG, the heart is enlarged by both chamber dilatation and hypertrophy. Dilation across the tricuspid valve can initiate mild regurgitant flow, causing a normal grade 1 or 2 systolic murmur in pregnant women. Upward displacement of the diaphragm by the enlarging uterus moves the apex beat outwards and upwards. So the apex beat may be in the 4th intercostal space and lateral to the mid-clavicular line in the pregnant woman. These changes lead to ECG findings of left axis deviation, a sagging ST segment, and T-wave inversion or flattening in lead 3. Moving on to the hematological system, we mentioned earlier that the red cell mass increases by 20 to 30%. Leukocyte count is variable during pregnancy, but usually remain within the upper limits of normal, though marked elevations develop during and after parturition. Fibrinogen, total body and plasma levels of factors 1, 2, 5, 7, 8, 9, 10, and 12 increase markedly. Factors 11, 13, as well as antithrombin 3 levels decrease. The number of platelets also rises, yet not above the upper limits of normal. And this is combined with a decrease in fibrinolytic activity. All these changes tend to make pregnancy a relatively hypercoagulable state. And this prevents bleeding at delivery, but increases the risk of thromboembolic complications. Pregnancy is a pro-thrombotic state. At delivery, there is an increase in fibrinolytic activity, especially the third stage, and a high concentration of plasminogen activators in the uterus, both of which may activate disseminated intravascular coagulopathy. So there is a change in the trend. During pregnancy, these factors tends towards giving a pro-thrombotic state, and following delivery, there is high concentration of plasminogen activators, which can now result in consumption coagulopathy. The plasma albumin concentration is reduced, but globulin and fibrinogen concentrations increase. Overall plasma protein concentration drops to 65 to 70 grams per liter. This is associated with a decrease in total colloid osmotic pressure and an altered drug binding capacity. Plasma concentration of pseudocholinesterase decreases by 25% in pregnancy, and there is an increase in erythrocyte sedimentation rates and blood viscosity. Looking at the respiratory system, hormonal changes lead to capillary engorgement and swelling of the mucosa of the nose, oropharynx, larynx, and trachea. Symptoms of nasal congestion, voice change, and upper respiratory tract infection may prevail throughout gestation. These symptoms can be exacerbated by fluid overload or edema associated with pregnancy-induced hypertension or preeclampsia. As such, manipulation of the airway can lead to profuse bleeding from the oropharynx. Endotracheal intubation can be difficult, and a smaller than usual endotracheal tube may be required to fit through the larynx. So usually for the pregnant woman at term coming for cesarean section, for example, we should prepare a tube that is 0.5 or 1 size below the appropriate for that woman. The airway resistance is reduced as a result of progesterone-mediated relaxation of the bronchial musculature. This is an advantage, reduced airway activity. Although edema is increased, swelling is increased, and then the tissues are friable. Upward displacements by the gravid uterus causes elevation of the diaphragm, but total lung capacity decreases only slightly because there is a compensatory increase in the circumference of the chest by 5 to 7 centimeters, and there is also opening up of the ribs. These changes are brought about by hormonal effects that loosen ligaments. Breathing is more diaphragmatic than thoracic during gestation, as chest wall compliance is decreased, though lung compliance is relatively unaffected. From mid-second trimester, the expiratory reserve volume, residual volume, and the functional residual capacity decrease progressively by approximately 20% at term. Tidal volume rises by 40% and respiratory rate rises by 15%. This results in progressive increase in minute ventilation, which starts soon after conception, peaks at 50% above normal levels around the second trimester. The dead space remains unchanged. Therefore, alveolar ventilation is about 70% higher at the end of gestation. Arterial and alveolar carbon dioxide tensions are decreased by the increased ventilation. An average arterial carbon dioxide tension of 32 millimeters of mercury and arterial oxygen tension of 105 millimeters of mercury persist. And compensatory decreases in serum bicarbonate prevents development of alkalosis. This pictorial diagram attempts to summarize the changes that occur in the respiratory system in pregnancy. And these changes are due to two major factors: hormonal and mechanical. There is the enlarging uterus, which displaces the diaphragm upwards. And this leads to apposition of the zones. There is an increase in zone of apposition. This same reason of displacement, upward displacement of the diaphragm, also reduces the functional residual capacity as well as the expiratory reserve volume. The total lung capacity is slightly, the change is not much in the total lung capacity and the vital capacity, but the inspiratory capacity increases. The increase in abdomen dimensions and the rib cage dimensions are also responsible for these changes. There is lower rib cage contribution during, there is increased lower rib cage contribution during tidal volume, resulting in an increase in tidal volume, which also leads to an increase in minute ventilation. Increase in minute ventilation gives rise to increase in arterial oxygen tension and a decrease in carbon dioxide tension. Progesterone rise increases oxygen consumption. The anesthetic implication is that general anesthesia wouldn't be the routine choice for cesarean section because the intubation is more difficult. The enlarged breast prevents good application of the laryngoscope. The handle of the laryngoscope can be obstructed by the enlarged breast. The edema of the airway makes intubation more difficult. There is increase in oxygen consumption and a decreased reserve due to reduced functional residual capacity. This can result in a rapid fall in arterial oxygen tension during apnea. And this occurs despite adequate pre-oxygenation and maternal positioning. The increased minute ventilation combined with a decrease in functional residual capacity hastens inhalational induction or changes in depth of anesthesia when breathing spontaneously. This means that the FRC is reduced, hence the inhalational anesthesia achieves a faster induction. But because the respiratory rate is also high, minute ventilation is increased, the washout rate is also high. So there is an increase in onset and offset of anesthesia. And this, the increase in offset could contribute to, the increase in onset will contribute to light anesthesia. Failed intubation rate increases to 1 in 250 and is worse in the obese patients and pre-eclamptic patients. There's also an increased risk of aspiration because of the gastrointestinal changes, which I'll discuss in the next slide. The enlarging uterus causes gradual cephalar displacement of stomach and intestines. At term, the stomach is vertical rather than its normal horizontal position, resulting in an increase in intragastric pressure, a change in the angle of the gastroesophageal junction. It becomes less acute, and then there is increased esophageal reflux. The intragastric pressure is normally 7 to 8 centimeters of water. This is doubled in pregnancy and can be as high as 40 centimeters of water with multiple gestation and in the obese. As early as 8 to 10 weeks of gestation, there is increase in gastric volume and a decrease in pH, with delayed gastric emptying only occurring during labor and delivery. The pregnant woman is therefore a full stomach patient with increased risk of aspiration during most of gestation. Aspiration of acidic gastric contents will result in chemical pneumonitis, known as Mendelssohn syndrome. The danger of aspiration is almost eliminated when regional anesthesia or inhalational analgesia is used. A non-particulate oral antacid, sodium citrate or bicarbonate, should be given immediately prior to induction of general anesthesia to all women. In addition, histamine receptor antagonists the night before and morning of delivery may reduce secretion of hydrochloric acid. Commonly used is ranitidine, 150 milligram orally, the night before and morning of surgery. If coming as an emergency, then administration of 50 milligram intravenous ranitidine within the first 30 minutes prior to induction is recommended. For those requiring general anesthesia, supine position with a lateral tilt will minimize further increase in intragastric pressure. Rapid sequence induction and intubation of the trachea with a cuffed endotracheal tube should be employed. Pre-oxygenation prior to induction, and there should be no positive bag mask ventilation prior to insertion of the endotracheal tube. Cricoid pressure should be applied during induction and maintained until endotracheal tube has been correctly placed in the trachea and has been confirmed. All metabolic functions increase in pregnancy. Protein metabolism increases to cater for the needs of the mother and the growing fetus. Lipid metabolism also rises in pregnancy, as shown by an increase in fraction of all lipids. Carbohydrate metabolism shows the most dramatic changes. Hormones such as human placental lactogen, progesterone, prolactin, and cortisol, together with reduced liver enzyme activity of glucokinase and phosphofructokinase, result in an insulin-resistant state. However, normal women will not come down with insulin resistance because they counteract this by increasing insulin production. However, those with gestational diabetes would not be able to do this, and they come down with gestational diabetes. By 15 weeks of gestation, maternal blood glucose levels after an overnight fast are considerably lower than in the non-gravid state. This is due to expanded maternal blood volume, increased placenta transfer of glucose to the fetus, and a decrease in renal threshold. Plasma concentrations of alkaline phosphatase increase threefold in pregnancy due to production by the placenta. Protein synthesis is reduced, leading to reduced plasma cholinesterase concentrations. This may cause prolongation of neuromuscular blockade after administration of succinylcholine, but this is rarely clinically significant. It has been said that following delivery, plasma cholinesterase falls by up to 33%, and in such patients, there may be a delay in the action of, there may be prolongation of the action of succinylcholine in them. Now, looking at the renal system, renal plasma flow and glomerular filtration rates increase progressively from the first trimester. At term, both will have increased by about 50 to 60% as compared to the non-pregnant state. Creatinine clearance is elevated. Blood urea and serum creatinine are reduced by 40%. The increase in GFR may overwhelm the ability of the renal tubules to reabsorb, leading to glucose and protein losses in urine. So there may be mild glycosuria and or proteinuria in pregnancy, which is considered to be normal, as long as the glycosuria is within 1 to 10 grams per day, and the proteinuria is not more than 300 milligrams per day. The activities of the renin-angiotensin-aldosterone system and progesterone are increased. This leads to sodium and water retention, conservation of potassium, and reduced plasma osmolality. After the 12th week of gestation, atony of the renal calyces and ureters can result from the effect of progesterone. The enlarging uterus can compress on the ureters as they cross the pelvic brim, leading to obstruction to flow and further dilatation. These changes may contribute to the frequency of urinary tract infections during pregnancy. This is a summary of the changes in the renal system in pregnancy. Those factors that are increased include renal plasma flow, glomerular filtration rates, urine volume, glycosuria, proteinuria, and creatinine clearance. And the following are decreased: renal tubular reabsorption, plasma urea concentration, and plasma creatinine concentration. We shall look at the central nervous system changes. When talking about the cardiovascular changes, we mentioned aortocaval compression. It also has an implication on the epidural veins because it makes them more engorged, and then this decreases the volume of the epidural space. So solutions injected will spread more extensively. Cerebrospinal fluid pressure is increased by the same aortocaval compression, as well as by uterine contractions in labor. However, the constituents of the CSF and its specific gravity remain unchanged. Sympathetic nervous system activity increases and is maximal at term. The effect is largely on the venous capacitance vessels of the lower limbs and counteracts inferior vena cava compression by the gravid uterus. Hence, sympathetic block due to spinal or epidural anesthesia can result in a marked increase in blood pressure in pregnant women as compared to non-pregnant women, non-pregnant patients. The anesthetic implication is that local anesthetic doses for epidural and spinal anesthesia are reduced due to decrease in volumes of the epidural and subarachnoid spaces. The same way AORTOCAVAL compression contracts the epidural space, there is a similar effect on the subarachnoid space. There is increased nerve fiber sensitivity to local anesthetics, and there is a decrease in arterial carbon dioxide tension, which leads to reduced buffering capacity. So local anesthetics will remain as free bases for longer. They will act for longer. We know that carbon dioxide reacts with water to form carbonic acid, which dissociates in the presence of carbonic anhydrase, giving rise to hydrogen ion and bicarbonate. The hydrogen ion is the proton, so combines with free bases, neutralizes. When CO2 is decreased, then hydrogen ion production also decreases. And then we have the bases being acting for longer. The minimal alveolar concentration of inhalational agents is reduced by 40%, possibly due to increased progesterone levels. Looking at the musculoskeletal system, there is general ligamentous relaxation because the placenta produces a hormone known as relaxin in pregnancy. Relaxin widens pubic symphysis and increases joint mobility. As the uterus enlarges, lumbar lordosis is enhanced and often results in low back pain. Also, there is tendency to dislocation in pregnancy as the joints are relaxed. The mobility of the joints also increase. There is weight increase by 10 to 12 kg in pregnancy. And what contributes to this weight are an increase in water and fat in the body, the fetus, the placenta, amniotic fluid, and the enlarging uterus. The breast also contributes to the weight gain in pregnancy. In the setting of cardiopulmonary arrest in a pregnant woman, how do these physiological changes impact to cardiopulmonary resuscitation? We have the same basic principles of resuscitation in the pregnant woman as in any patient. However, certain modifications are necessary to account for the physiological changes that occur during pregnancy. And these modifications are left uterine displacement to relieve the compression of the inferior vena cava and aorta by the gravid uterus. This can be done by standing on the right of the patient and moving the gravid uterus upwards and to the left. It can also be done while on the left side of the patient by cupping the gravid uterus and pulling it towards self. upwards and leftwards. Another modification is to intubate using rapid sequence induction with application of cricoid pressure. Timely perimortem cesarean section within 5 minutes of cardiac arrest if there is no return of spontaneous circulation and resuscitation is deemed unsuccessful. The perimortem cesarean section is performed if the gestational age is at least 20 weeks or the gravid uterus is evident. Now, the other things that wouldn't change is to give high quality cardiopulmonary resuscitation. That's chest compressions should be hard and fast. Hard meaning the compression should have adequate depth of 5 centimeters and we should allow for complete chest recoil. Fast in the sense that 100 chest compressions should be given within a minute. The placement of the hands should be same as in the non-pregnant, in the lower half of the sternum. And the use of drugs such as adrenaline in advanced trauma life support, advanced life supports is same as for the non-pregnant. There is no dose adjustment required. AED should also be used in the pregnant woman during cardiopulmonary resuscitation if indicated. And there should be no delay. There should be no interruptions in CPR. Interruptions should be minimized to less than 10 seconds. So if there are internal or external monitors attached to the fetus, there should be no delay trying to remove these monitors before application of shock in a shockable rhythm. Now, looking at high-risk gestation, it is one in which the mother or the fetus has an increased risk of adverse outcomes. An example of conditions that constitute high-risk gestation include maternal age less than 16 years or above 35 years, chronic medical conditions like hypertension, diabetes, cardiovascular or renal disease, thyroid disorder, sickle cell anemia, thalassemias, pregnancy-induced hypertension. I brought this out because as against chronic hypertensives, rhesus ISO immunization, multiple gestation, post-term pregnancy, previous cervical incompetence. There's going to be a webinar on high-risk gestation where this will be discussed extensively. In conclusion, a good understanding of the physiological changes in pregnancy is essential in the management of the well woman, as well as those women who have a pre-existing medical condition. This gives the anesthetist the ability to provide quality perioperative care to the pregnant woman. Knowledge of the principles of cardiopulmonary resuscitation in a parturient in the healthcare team is crucial to expedite positive outcomes for both the mother and her fetus. Thank you for your attention, and these are my references. Thank you. Questions, comments, and contributions?